Welcome to fourth personalized surgery podcast. As I mentioned earlier, in this personalized surgery podcast, we try to bring renowned surgeons and learn from them how they are leveraging personalized surgery across the globe. It is an honor today to have Dr. Mandip Shah with us, who is an orthopedic oncology surgeon. Welcome, Dr. Mandip Shah.
Thank
It's
you.
a pleasure to have you today
Thank
in
you.
our podcast. Dr. Mandip Shah has more than 2 decades of experience in orthopedic oncology. He runs a beautiful hospital here at Sparsh Hospital in Ahmedabad. He's worked at multiple globally renowned centers, including Tata Memorial Hospital in Mumbai, MSK in New York, Mount Sinai in Canada, as well as NUH in Singapore. And he brings a wealth of experience in orthopedic oncology. And today we are going to talk about oncology on bone tumors and soft tissues and osteosarcomas and some of the things that we would learn today. Welcome, Dr. Shah. It's a pleasure to have you today, and I'm going to just jump to the questions. How did you end up doing this? Like, what inspired you to do this?
Well, before I answer your question, I would first want to congratulate you that someone at least thought of having a podcast on bone tumors and bone cancers, because these things are so rare that many of the, forget about lay people, even many doctors don't even know about the sarcomas, because they are so rare. If you make a list of cancer with the commonest cancer at the top and the rarest cancer at the bottom, sarcomas as a group, it consists of almost 126 different variants of sarcomas. As a group, they feature at the fourth from the bottom. So it is so rare that nobody even thinks of bringing awareness about these things. But they are very rare, and that is why they are most likely to be mistaken for something else. And that is, it is important to have awareness about sarcomas, and for that I would congratulate you that you are taking this effort to bring this up in front of society.
Thank you.
Now, coming to your question, when I was doing my post graduation in orthopedics back in year 2002, I was about to appear for an exam, and I was reading about. I started reading about orthopedics, various specialties of orthopedics, and I was coincidentally reading about oncology, and I was reading about all these big surgeries and mega prosthesis and rotation plasties and pelvic resections. And I happen to think that, okay, these things probably are, for me, they're in books, and I don't think these things are happening in India.
Right.
And I happened to travel to Chennai for our national conference when I was a third year resident, and I saw Professor Puri, who is my mentor and who is a renowned figure in orthopedic oncology, actually present these surgeries in front of us as a white paper. And that really made me aware about these things, that these things are happening in India. And then immediately I thought of taking this up, because as a surgeon you want to do this kind of, as the ultimate fantasy of an orthopedic surgeon is to do an orthopedic oncology case. And you ask any orthopedic surgeon and they would say, okay, I can do this, I can do this, I can do this, but I cannot do this. So oncology as a specialty is, because it's very challenging, it also is very, very satisfying when you do this surgeries. And then as I stepped into this specialty, thinking that because there are not many people in this field, it will be easier for me to have a foothold in the competitive world of orthopedics in Ahmedabad. But when I actually started learning about oncology, then I realized that this is one branch where you really make a difference in someone's life. And see, every doctor earns, but people like us who are orthopedic oncologists, they earn a lot of blessings as well. So this is something where you can make a huge difference in not only the patient's life, but in the surrounding family
Yeah.
and the
Yeah.
society. So this is one really, I would say, very very, at the same time fascinating, exciting, amazing, but at the same time really really satisfying branch. And that is why I ended up here.
Amazing, so
Yeah,
much
yeah,
inspiration, and
yeah,
it's like uh, the happiness that you can get and the impact you can have to the
absolutely.
society is
Yes,
just
yes, yes.
it's beyond
That's true.
beyond any measurements or any financial benefits. So
That's
it's
true.
it's really, so maybe a follow-up question, like how do you suspect that, because even though these are rare,
Yeah.
how do you suspect that this patient has a cancer or a potential cancer? Like where do you start, like what do you do?
It's a very good question, Ketan bhai. I mean, see, most patients would initially, go to a general orthopedic
Hmm.
surgeon. See, and most of our sarcoma patients, they are young patients.
Hmm.
So, when a 14-year-old complains of a pain in the knee joint,
Yeah.
he goes to a doctor and
Hmm.
he would say, oh, he must have injured himself by playing a football or a
Hmm.
cricket. And he gives some medicines, and, for some time the pain goes away and then again it
Hmm.
comes back. So, as a ballpark, we tell all the orthopedic surgeons that if a young boy comes
Hmm.
to you
Hmm.
2 times in 15 days interval complaining of pain,
Hmm.
or a swelling which is actually not painful but there is a swelling, then just go for an MRI, because an MRI can save a life. It's
Hmm.
such a simple investigations.
Hmm.
So most of these tumors would start as painless swellings, but when they achieve a specific size, they usually become painful.
Hmm.
So, your index of suspicion should be high.
Hmm.
Getting an MRI doesn't lose, you
Yeah.
don't lose anything by getting an MRI, but sometimes not getting an MRI can be very costly.
Hmm.
You
Hmm.
know,
Yeah. So, one of the modality, like you mentioned, is MRI. Like,
yeah.
when do you use, say, CT or ultrasound or other pathological, including, say, angio CTs?
Right. So the first and simple investigation that we do is an X-ray.
Okay.
An X-ray usually
Hmm.
is diagnostic for
Yeah.
majority of the bone tumors
Yeah.
and bone cancers. Uh, Primarily, the MRI is done for confirming what you are seeing on X-ray, and also it will tell you the extent of the disease. The
Hmm.
soft tissue extent, the bone extent, how long it is involving the bone, and what of the muscles are involved, whether the blood vessels are involved or not.
Hmm.
So essentially, MRI is used for surgical planning
Hmm.
when we're doing a surgery. But even as an initial investigation for diagnosis, also is very important. Uh, Again, CT scan, sonography, angiographies, they are all usually supplement to the MRI.
Hmm.
For when you are planning to do a surgery, most of these are, they help us for planning of the surgery.
Hmm.
But primarily the diagnosis is made based on X-ray,
Hmm.
MRI, of course the clinical presentation, X-ray, MRI, and then we always do a biopsy. And that is
Okay.
something which many of uh, the surgeons, they avoid. They usually blindly trust the report of the MRI. Suppose there is a mass in the thigh and the MRI guy has written that it is a hematoma,
Hmm.
and he would just go in and take it out as a hematoma, and then he would be surprised
Hmm.
to find the histopathology report as a sarcoma, and that is actually a big disaster which has
Yeah.
already happened. So we always tell patients and doctors rather, then,
Hmm.
or doing a small needle biopsy doesn't cost you anything,
Hmm.
but not doing a biopsy can again be very costly.
Yeah.
So the diagnosis is made by basically with the help of a biopsy,
Amazing. So,
and these biopsies are done with a very small needles
yeah.
these days. Previously there used to be big incisions and doing biopsies with big incision. Now we do biopsies with a 2 millimeter
Nice.
diameter, bone
Yeah.
needles.
Yeah.
They're very simple investigations. Yeah.
Amazing.
Yeah.
So early diagnostic and
Yes.
finding it faster kind of
Absolutely.
helps. So
Yes.
how do you kind of stage these? Like, let's say once there
Yeah.
is an identification, okay, this
Yeah.
patient has this. What do
Correct.
they do next, and what are some of the treatment options?
Wonderful. So it's important to stage a cancer. Whenever the patient comes to us, sir, what stage, कौन से stage में है sir ये
Hmm.
cancer?
Hmm. Hmm.
क्या मैं अच्छा होऊंगा कि नहीं होऊंगा?
Hmm.
Whether I'll be cured or not? What stage of the cancer it is? It's very important because we all know that uh, a patient who is in first stage, second stage cancer, they are eminently curable. But the
Nice.
patients who are, say for example, in third stage or fourth stage,
Hmm.
it's very difficult to completely eliminate the cancer from those patients.
Mm-hmm.
So usually when we do a staging, or when we have to tell the patient that you are in stage 1 or 2 or 3 or 4,
Mm-hmm.
we usually look at two or three things.
Mm-hmm.
One, how aggressive is the cancer, whether it's a slow growing cancer or a
Mm-hmm.
fast growing cancer, meaning by
Mm-hmm.
low grade or high grade.
Mm-hmm.
What is the size of the cancer, whether it's smaller than 5 centimeters, bigger than 5 centimeters, whether it is
Mm-hmm.
only inside the bone or inside and outside the bone, and more importantly whether it has already spread to any other part of the body. So basically considering these couple of things, we stage the cancer.
Mm-hmm.
And the majority of the cancer today present to us in second stage.
Okay.
I would say 8 out of 10 patients would present to me in second stage,
Okay.
and other three stage would consist of around 20% of the cases.
Sure, sure.
Yeah.
So how do you treat this, right? So once you've identified the stage, like
Yeah.
what are some of the treatment options available?
So basically, as I just mentioned, there are 126 different types
Right.
of sarcomas, but
Right.
the commoner, if you talk about the bone sarcomas,
Mm-hmm.
the commonest would be osteosarcoma and Ewing sarcoma and chondrosarcoma.
Mm-hmm.
So they are primarily the most common bone cancers that they present to us. And in osteosarcoma and Ewing sarcoma, the treatment would typically start with chemotherapy.
Okay.
So the purpose of giving chemotherapy before surgery are basically two purposes. One, we want to kill those cancer cells which are circulating in his body through the bloodstream, because we know that sarcomas, the moment they develop in the body, they shower multiple cancer cells in the bloodstream, and they're all circulating in the patient's body. So by giving chemotherapy in the blood, we're killing those cancer cells which we call micrometastasis, which we can't see but they're there.
Yeah.
And it is observed that in 95 out of 100 times, by giving chemotherapy, the tumor shrinks. The size of the tumor becomes smaller. um, it becomes more firm. The blood supply around it reduces, the swelling around it reduces, and it makes it that much easier for us to do a limb preservation surgery, meaning by we want to save the leg, we don't want to amputate it, because in good old years the only treatment for bone cancers was to amputate. If there is a cancer here, you amputate from here. If there is a cancer here, you amputate from here. That was the only treatment. But nowadays 98 out of 100 times we end up doing limb salvage surgery. So limb salvage surgery is more safer when the patient has responded well to chemotherapy. So in osteosarcomas and Ewing sarcomas, the treatment starts with chemotherapy. But there are some other sarcomas like chondrosarcomas where there is no role of chemotherapy, and we do go for direct surgeries. So first line of treatment in osteo and Ewing sarcomas would be to go chemotherapy, and then we will do a surgery on those patients. And those surgeries are typically, as I said, they are known as limb salvage surgery or limb preservation surgeries.
So
Yeah.
tell us about limb salvage. So the term salvage to a layman is like, okay, you're just getting rid of it, right? So I mean, as a
Right.
layman, that's how we think about it.
Right.
But I guess the meaning is a little bit different.
Yeah.
So maybe if you can share like why a limb salvage surgery really helps,
Right.
and why not, and how do you decide whether you should do amputation or a limb salvage surgery? And
It's an excellent question. Ketan bhai, so the first question that patient asks us many times, now we are in 2026, but when I started my practicing back in 2007, the first question patients would ask me would, sir, is the limb salvage surgery safe or not? Even if my son loses his leg, but if he's cured, then I don't mind losing the leg. I want my son to be alive.
Yeah.
And whether the limb preservation surgery is safe or not. And it's a very logical question, because life comes first,
Yep.
leg comes next,
Exactly.
and then the rest. Now, uh, we have multiple studies and research which has happened. Of course, we cannot have head-to-head comparison between amputation and salvage, but we have a lot of literature support which has confirmed that a properly done limb preservation surgery under the cover of chemotherapy and whenever needed radiation therapy is as safe as amputation. Meaning by, if I explain to you in a layman language, you take 200 patients of second stage osteosarcoma, say for example, you give them chemotherapy, out of them 100 you amputate and 100 you do a proper
Mm.
limb preservation surgery, out of this 100, 70 will survive. Out of
Right.
this 100 also 70 will survive.
Right.
So by doing an amputation, we are not making any advantage, making any benefit to the patients by in terms of survival advantage. Meaning by, if by doing an amputation all 100 patients would survive, it's a no-brainer.
Right.
But there is no difference in overall survival when you do amputation or a properly done limb preservation surgery.
Right.
And that is where it has been written in our guidelines, in our books, and there have been multiple, probably thousands of reports which confirms that limb preservation surgery is very safe. So it is very safe, that is one thing. But as I use this word, properly performed limb preservation surgery, that is the most important thing.
Yep.
Because there is a methodology of performing a limb preservation surgery, and that is where the role of margins comes. So if you have to cut a tree, suppose a tree has multiple branches, it has a it has a big
Trunk
trunk and all. So you could cut one by one by one by one by one branches, and then you could cut the trunk in pieces, and then you could cut it from its ground.
Yeah.
But still the roots are still there inside, and it is going to grow up again.
Grow up.
The other way of cutting the tree is to go far away, dig a big pit,
Yep.
and take it out with its root.
Right.
And that way you make it sure that it never comes back.
Understood.
So in limb salvage surgery, the most important thing is to do a wide margin excision, meaning by take out the cancer along with all its roots. And that is where if the cancer is this much, we take out this much. You have to have negative margins in all 6 directions, to the top, to the bottom, to the left, to the right, to the front, and to the back. And you have to take it out with negative margins in all 6 directions. That is where, if you have done a limb salvage surgery in that particular way, then only you can call it a safe limb salvage surgery.
Understood.
And when you do that, the patient loses a lot of bone, patient loses a lot of muscles, and but be it, so as I said, the first goal is to save the life.
Yeah.
Because if there is life, there is limb.
Yeah.
So of course the patient is going to lose a lot of muscles, the patient is going to lose a lot of a large piece of bone. But there are ways of reconstructing those defects.
Yeah.
I mean, bony defects can be reconstructed efficiently now with lots of options. Even the soft tissue defects, most of those defects are either inconsequential or compatible with decent or good function.
Yeah.
I mean, if you lose some muscles, of course God has not given anything in our body which is useless.
Correct.
Everything has some function. But even if, say for example, if you have to do this movement, there are 4 muscles doing that movement. If you have to lose 2 out of those 4, that movement becomes a little weaker, but it doesn't go away.
Yeah.
You understand? So when we do a limb salvage surgery, we also balance kind of oncology and function both. But of course oncology will always supersede and precede over function.
Right.
So, and what we follow is, if you cannot get wide margin, don't hesitate to amputate.
Right.
Even today, out of 100 cases, 3 unfortunate patients have to undergo amputation. That is,
There is no other choice.
there is no other choice, we have to do that.
Yeah. Understood. So when you talk about margin, like typically, like these are in joint space, right?
Right.
Either like a knee or a hip.
Correct.
And how do you, because these are also growing and growing
That's
very
right.
fast.
That's right.
How do you choose these margins
Right.
intraoperatively? Because it's also growing at that time.
That's right. So